Welcome once again to 10 Minutes with Harry. We are currently doing a series on the interpretation of the normal pacemaker electrocardiogram. And today we are doing number 6, where am I pacing from? One of the least understood aspects of the 12-lead ECG on cardiac pacing is interpreting on that tracing of where the pacing lead is. This is, we can in fact look at both atrial and ventricular pacing, but today I'm going to focus on how to determine the ventricular pacing site on the 12-lead ECG. We have 4 identifying ECG features. The first is obvious, the stimulus artifact confirms pacing. The second is that there is a bundle branch block configuration. I need to stress the importance of that word configuration, because when you are pacing the heart, you generally have a wide QRS, and that it has the appearance of either from the right ventricle, which is a left bundle branch block configuration, and from the left ventricle, a right bundle branch block configuration. But it is not traversing the conducting system. So in fact, it's not a true left bundle branch block or a right bundle branch block, but rather it mimics it, and that's why we call it a configuration. There are 2 other identifying features for right ventricular pacing. The first is that the R waves from V4 to V6 give us the position in the ventricle, as does the frontal plane axis. It gives you a normal, right, left, or indeterminate axis, tells you where the lead is. Let's now look at right ventricular pacing. Here we are with a lead at the apex of the right ventricle, and now a 12-lead ECG showing firstly, that the first feature is that there is a left bundle branch block configuration, hence right ventricular pacing. But where is it in the ventricle? Well, the V4, V5, V6 have no R waves and just S waves when you are pacing from the right ventricular apex. And the other identifying feature is that there is a left or an indeterminate axis. And so we can look at this and very accurately determine that this is apical. The other area to the opposite, of course, is the right ventricular outflow tract. And here we have an ECG, and the features are, of course, left bundle branch block configuration, because it's the right ventricle we're pacing in. But now V4 to V6 is very different than the apex. And we can see here there are R waves in V4 to V6, and the axis is that of a normal or even a right axis. Here is an ECG showing the S wave in 1, showing the right axis deviation from the right ventricular outflow tract. The other area of the heart, the right ventricle, is the mid-ventricular position. And how do we tell that? Well, it's a transition zone, so that we have, of course, a left bundle branch block configuration, and we have R waves in V4 to V6, and you can tell by the development of these R waves where it actually is in the right mid-ventricle. In this situation, it's rather low down, so we don't have anything, no R waves in V4. Similarly, the axis is that of a left axis deviation, and showing once again, it's fairly low down, but only go a few millimeters superior and the axis changes quite dramatically. What about left ventricular pacing? This can be either intentional or non-intentional. Intentional left ventricular pacing is when you have the lead placed in the left ventricle, and you know it is there. For instance, in this case, epicardial leads in a congenital heart disease patient, and it's high on the left ventricle. So, of course, we're going to have a right bundle branch block configuration because it's left ventricle. And because it is high, the axis is going to be right. So we can tell very accurately where the surgeon has placed the lead on the heart. Here is a situation, corrected transposition of the great vessels. It's congenitally corrected so that the ventricles are inverted. On the left side, we have the morphologic right ventricle, and on the right side, we have the morphologic left ventricle. Why is this transposition? Well, when this happens, the aorta now lies in front and the pulmonary artery behind. When this happens, there is stress on the conducting system, and therefore congenital complete heart block is not uncommon, and therefore we see congenitally corrected transposition of the great vessels not infrequently. Here is a chest X-ray giving the appearance of the classical appearance. You can see that the right lead, the right ventricular lead, which is of course in the morphologic left ventricle, is in a small chamber and it's twisted towards the right. People can spend hours trying to pass such leads across the tricuspid valve, but of course the tricuspid valve is lying straight up and down, and this is the easiest implant to do. On the left lateral, it is lying anterior in the chamber. What about the ECG? Here is an ECG from such a patient, and not surprisingly, there is a right bundle branch block configuration, and because it's now apical, we know that the lead is a left axis, or as you can see here, an extreme left axis. What about unintentional left ventricular pacing? This is the situation where I call it, oops, I made a mistake. Because the person who is implanting the pacemaker in the right ventricle inadvertently places it in the left. So we'll have a look at a number of examples of this. However, before we start, let us have a look at this ECG, which, as you can see, shows a right bundle branch block configuration and a left axis. So you would say that this is at the apex of the left ventricle. However, this is the post-mortem of the patient, and the heart and the lead lies at the apex of the right ventricle. Why then is it left ventricular pacing? It is believed that there is preferential left ventricular activation via the His-Purkinje system and having bridges there. And it preferentially depolarizes the left ventricle first. This occurs occasionally, and you get all levels of right ventricular, right bundle branch block configuration. Now let's have a look at some of the unintentional. Here is a model of the heart, cartoon showing the coronary sinus and the lead now passing into the coronary sinus rather than going through the tricuspid valve into the right ventricle. So here now it's lying on the back of a heart. You can see it can either pass into a vein directly, the middle cardiac vein, which is very low down, or a more lateral cardiac vein, a little higher up on the coronary sinus. One should be able, therefore, to determine this on the 12-lead ECG very easily. For instance, here is a middle cardiac vein. Lead looks as if it's at the apex of the right ventricle, but when one looks at the left lateral, it is passing posterior. It's lying on the back of the heart. The ECG, therefore, shows a right bundle branch block configuration, and because it's apical, it's a left axis deviation. Very easy. What about a lateral cardiac vein? Here you can see a demonstration of the lead lying in a lateral cardiac vein, a little higher up on the silhouette of the heart, and going posterior, meaning that it's on the epicardial surface at the back. ECG shows, of course, right bundle branch block configuration, and now because the lead is higher, it is no longer a left axis deviation, but rather a normal axis. What about an atrial septal defect or a patent foramen ovale? The lead then is passed into the right atrium, crawls up the septum until you find the atrial septal defect, and passes then into the left atrium and then into the apex of the left ventricle. And here is a classical a chest X-ray. And this is the classical appearance, although I've had to highlight it as the leads could not be well seen. And the 12-lead ECG clearly shows a right bundle branch block configuration. It's at the apex of the left ventricle, and in this case, it's a left axis or an extreme axis deviation. What about right ventricular perforation? Here we can see the temporary lead is, a permanent lead has passed to the apex of a right ventricle and has then crawled up on the epicardial surface and now lies on the left ventricle. And you can guess then, if this continues to pace, then it's going to have a right bundle branch block configuration because it's left ventricular pacing, and because it's high up, we're going to see a right axis deviation rather than the apex where it is left. Finally, let's have a look at this case and let's work through and see if we can work out where the lead is. Firstly, it's a right bundle branch block configuration. That's not difficult at all. Secondly, there is a right axis deviation. So we now know that this lead lies in the left ventricle and it is high up, or relatively high up. Let's have a look at the chest X-ray, and we can see firstly that this is a temporary lead, and the lead has inadvertently been passed through instead of the femoral vein, in the femoral artery, up the aorta retrograde, across the aortic valve, and high up in the left ventricular chamber. Then here is where the permanent lead is implanted later on. So this is temporary left ventricular pacing via the femoral artery. So what have we learned today? The bundle branch block configuration, the frontal plane axis, and the presence of R waves in the lateral chest leads provide a very accurate means of determining the site of ventricular pacing.